everyone. So now we are going to start the most awaited IC of AIOS, the cataract armamentarium, and we will talk about everything from ECCE to femtolaser. So at the outset, I would like to invite Professor KPS Malik. Okay, sir. So in this IC, we will talk about ECC, then SICS, and then we'll talk about phaco, then migration of phaco surgeons to SICS, the multifocality achieved through SICS, and the femtolaser surgery. So let's start with Professor Ruchi Goel, ma'am.
So I would be, thanks Pratyush for including me in this instruction course, and I would be talking about the basic concepts, that is what are the basic steps that you really need to learn perfectly to perform a good SICS. So the special indications where I would choose SICS as my first choice would be a high astigmatism, because simply by changing your size of the incision and the site of the incision, you can deal with high astigmatism till up to 3 diopters. If there is an extensive corneal opacity where doing a phacoemulsification is next to impossible, rocky hard cataracts where you don't want to jeopardize your endothelium, or a calcified anterior capsule where a complete rhexis is not possible. Now, just look at these patients. I had this patient which had a sclerosing keratitis all around. Where would you put your clear corneal incision in this case? So you have no choice but to do a SICS. This is a patient with radial keratotomy marks. If there are, if the marks are about 16, then you can go ahead and do a limbal incision. But if sometimes there are multiple marks and there is absolutely no place where you can make your clear corneal incision, then there is no choice but to go for a scleral incision. This is a patient of marginal degeneration. Again, there is no area where you can put your clear corneal incision. Now, there would be cases where there would be a contraindication for making a scleral tunnel. So look at this case. This is a scleral thinning, and this was caused by a sclerouveitis, recurrent sclerouveitis. This is a pre-existing bleb where you have to alter your site of incision. You can still go ahead and do a scleral incision, but not here. Now the types of incision, whatever incision you are going to make, whether it is straight or frown or whatever, it has to be made in such a manner that you create a tunnel which has a single plane. Don't create a tunnel which has multiple planes. The other thing is your internal incision has to be larger than your external incision. So as we divide the funnel into 3 parts, this is the external incision, this is the internal incision, these are the side pockets, and this is how you dissect. So now this is a imaginary area which was described by Dr. Koch, that is the incisional funnel, and he stated that any incision which is placed within this funnel would induce the least amount of astigmatism. So clearly you can see the more closer you are towards the limbus, the more astigmatism you are going to induce. One is that you are going around like a curvilineal incision, it's going out of this funnel. The second is that if you want to enlarge this tunnel, how do you enlarge? So the only option is that you move backwards. So that is how the frown incision came into existence. And to further add, now we have started doing 2 straight backward cuts on the same frown incision. Whenever you do the dissection internally, now let us see, you have made a good frown incision here and you have dissected internally. This should be about 2 millimeter, 1.5 to 2 millimeter. Again, this should be 1.5 to 2 millimeter. This should be about 8 to 9 millimeter. And the external incision is going to vary. The size is going to vary depending on the kind of technique you're using. If you're using a technique where your entire nucleus is brought out, obviously your external incision has to be larger. If you're using a technique where your nucleus is going to be broken either inside the NTA chamber or in the tunnel itself, then your external incision can be smaller. But there are claims, a lot of surgeons are claiming that they can do it in 2 millimeter, 3 millimeter, but advisable would be at least 4.5 if you're doing a phaco-fracture, minimum I'm talking about. Otherwise, I would go for a not less than 5 or 5.5, and if need be, if it's a very large nucleus, I would increase it sideways and increase it to 6 or more. So it is the safety which is more important rather than, you don't have to show your heroism anywhere. Now, these are the different techniques which have been used by different surgeons, and I think in the subsequent talks there would be a description of some of the techniques, and I would be showing you the Blumenthal technique. So this is a cataracta nigra, and nowadays what I do is I leave a frill of conjunctiva near the limbus so that you don't harm the stem cells. And it also helps in closing your wound properly. The wound gets covered by it. This is a frown incision, and this is the 0.5 millimeter depth of the external incision, followed by a crescent knife being used to dissect further into the cornea, about 1.5 to 2 millimeter. It is very important to use blades that are sharp, otherwise you don't have a very good dissection. I create 2 side ports nowadays instead of 1. It helps in stabilizing, especially if you're trying to do a topical, it helps in stabilizing. And this is the rhexis. Now remember, the size of the rhexis corresponds to the size of your nucleus. If you have a nucleus which is very large, don't try to make a small rhexis. By and large, your rhexis size has to be 6 millimeter or larger in SICS, but if it is a very large nucleus and you make a small rhexis, you will end up doing an intracapsular cataract extraction. If by chance you have ended up creating a small rhexis, you need to enlarge it further before you go in for prolapsing the nucleus into the chamber by giving 2 tangential cuts. Now, this is the anterior chamber maintainer. We hold it very close and fix it. Now see, the side port is used to stabilize the globe, and you enter and you always cut with the keratome in a forward direction. It is important to dissect laterally because this is where the nucleus is going to engage. After that, a good hydrodissection is done. If your size of the rhexis is corresponding to the size of the nucleus, the moment you try and do your hydrodissection, your nucleus will start popping out. Then remember to inject viscoelastic because this is a hard cataract, you don't want your endothelium to be damaged. So you inject viscoelastic in the front and by the sides. This is a SICS hook being used to dial the nucleus and prolapse it out. So once one of the edges is out, you can inject viscoelastic on the surface of the iris that will help in pushing the nucleus out further. You can also use different other techniques like hand over hand maneuver. So before the this is now the hand over hand maneuver being used to prolapse the nucleus out. It is a large nucleus with slightly smaller rhexis than what it required. So this maneuver helps. And again, lots of viscoelastic in front. After that, this is an iris repositor which is placed behind. I keep pressing on the sclera. The fluid is on. And the needle in the other hand is chipping the nucleus so that the nucleus becomes smaller in size. As the nucleus becomes smaller in size, you can keep on pushing the nucleus back to engage the smaller diameter. And eventually, as the nucleus engages into the internal tunnel, suppose the nucleus does not engage, that means your internal opening has to be enlarged. Now see, the nucleus has become smaller. I again inject the viscoelastic and re-engage the nucleus. Keep chipping it to bring it out. This may take a little longer time, but it is important that you must make an extra effort to keep on injecting viscoelastic, otherwise your endothelium gets damaged. Now once the nucleus is out, I don't use a Simcoe cannula, I just use the same cannula of what you use for high vis, that cannula through the side port with the interior chamber on and aspirate the cortex. This is especially useful for aspirating the 12 o'clock cortex. You can see how easily, without any injury to the posterior capsule, you can go quite behind. And there is no chance of collapse of the chamber. You can put the IOL either under fluid or under visco. Nowadays I prefer to do it under fluid only with ACM on. Now see, this is a patient where the CCC created was smaller. This is the tangential cut I was talking about. And this is the Utratas forceps. You can just simply enlarge it. Another cut on the other side. Now look at this patient. While I was doing the dissection, something went wrong. Can you see that dimple coming in? The moment you do a premature entry, see now the striations have also come. So that means you have had a premature entry and you stop there and then. Inject viscoelastic, complete your steps, and then the further enlargement needs to be done with the keratome, because at this stage if you do something, you are going to create a ragged wound. So never try to dissect when your eye is in a hypotenuse state. That is the most important thing. Inject viscoelastic. Either if you have done it at a very early stage, then you can inject viscoelastic, take another plane and start dissecting your tunnel in another plane. Otherwise you just do it with a keratome. Now this is another case where again there is a premature entry and the nucleus, while it comes, it may has a tendency for the iris to get incarcerated beneath the nucleus. So if your nucleus is not progressing and you have a doubt that there is a premature entry, then don't try. This is what you should not do. See what is happening now. So you just push back the nucleus, put in viscoelastic, re-engage your nucleus and then take it out. Otherwise you will end up with a superior iridodialysis if you keep on doing this. Now this is a situation where there is a buttonholing of the roof of the tunnel. So what happens is, as you inject as the fluid comes out, it keeps coming out through those ports, and again a leaky wound. You can see if your side ports are large, you can have a leaky wound. So what you need to do, you should suture these kind of tunnels wherever your wound is unhealthy. See, the superior wound is so ragged, so you need to suture these wounds. So never leave a leaky wound unsutured, because it's not about not suturing the wound, it's about giving a secure wound. That is most important. So thank you so much. Anything anybody wants to ask, most welcome. Thank you, Pratish.